So we're here today to talk about the Certified Community Behavioral Health Clinics, billing and payment information for clinics that are contracted with that program. I'm Jennifer Smith. I'm the Medicaid program trainer, and I have in the room with me
Jamal Furkan, policy analyst with the Oregon Health Authority and lead prospective payment system analyst for the demonstration grant.
And Eric Larson, the technician for the Wraparound payments.
All right, so here's what we're going to talk about today. We just had our introductions. We'll talk a little bit about our purpose for CCBHC, Medicaid enrollment for CCBHC, so just a little bit of information on that. If you do need to enroll, we'll just touch on that a little bit. We'll talk about the demonstration services crosswalk, billing and payment, the supplemental wraparound payment process, and that is for members who are enrolled in a coordinated care organization or managed care. And then other CCBHC billing considerations that Jamal has for you a little bit later in the presentation. So let's talk about the program and its purpose. And a lot of these are fairly brief until we get into the real meat of the presentation is when we get to billing and payment. So just a few things before we really dig into that. So this is a 2-year demonstration, and the program is designed to improve quality and access to behavioral health services for those who are suffering with mental illness and substance use disorders. And billing will begin on April 1st of 2017. So we really want to make sure that you're ready to go on April 1st of 2017 so we can move forward with our demonstration. And we're just going to touch on provider enrollment here and talk to you about the MMIS provider types. MMIS is our Medicaid Management Information System. And these are the IDs that you would need for billing CCBHC. So you're providing behavioral health services. They include substance abuse. And most claims under CCBHC require either the mental health or chemical dependency billing contract. So the provider type that you need to be enrolled as in our MMIS system allows each of those contracts. So the type 33 is a mental health provider, and it allows the mental health contract. And type 03 is alcohol and drug, and it allows that chemical dependency billing contract.
Yeah, and this is Jamal. All of the CCBHCs, you'll currently have Medicaid enrollment. And so we've confirmed, well, I should start with that. All of the CCBHCs should have received an email from me confirming your billing ID for the demonstration. We've received responses from 11 of the 13 CCBHCs. And what we're really looking to do is assign your PPS encounter rate to your Medicaid ID numbers so that when you bill for demonstration services, the system is able to reimburse you your PPS rate. So again, 11 of the 13 CCBHCs have already confirmed. I believe we're waiting on feedback from Community Counseling Solutions and Peace Health at this point. All of the other CCBHCs, we will be assigning your PPS encounter rates to the Medicaid ID numbers that you confirmed.
All right, very good. So let's go ahead and move into, again, I said that would be very brief. So that's it. We'll talk about the demonstration services crosswalk now. And the purpose of the crosswalk is really it's providing a seamless transition from OHP's behavioral health fee schedule. And it lists procedure codes that are eligible for reimbursement under the prospective payment system or PPS methodology. And it assigns the demonstration service categories that are outlined by SAMHSA to OHP covered procedure codes and specifications. So it takes each of the procedure codes and aligns them with those categories that are outlined. And then it's been developed in conjunction with CCBHC, PPS, subcommittee, and input from the clinic. So at the bottom of the page there, you'll see where we've linked to the CCBHC website where you will find the crosswalk. And I can go ahead and click on that now and show it to you as well. So here's the CCBHC website. And then if I just scroll down, the crosswalk is right here under Prospective Payment System Resources. So I'm going to click on that and open it. This is not it. You're looking at something different right now as it opens the other Excel spreadsheet. We'll talk about that other one a little bit later. So you can see here are the categories as outlined by SAMHSA right at the top, and they each have their explanation there. Oops, didn't mean to move quite that quickly. So you'll see those listed right here. And then you'll see procedure codes, and they are categorized under those categories. So you'll see that there. And then it also shows you required modifiers, allowed modifiers, a description of the code. Lots of great information here, and I'll just scroll over.
Yeah, and so the demonstration services crosswalk is really based on the behavioral health fee schedule. So if you've been using the OHP behavioral health fee schedule, you'll see that many of the same elements are still present in terms of the providers for each of these procedure codes that are allowed to bill under these particular codes and services. So really, and the required modifiers, all of those aspects that were previously established under the behavioral health fee schedule are still in place for the CCBHC demonstration procedure codes.
All right, thanks, Jamal. I'm going to go back to our slide. We do, yeah, I'm going to stop in just a second. All right, so that's the crosswalk, and now before we get into billing and payments, I want to see if we have any questions about some of that introductory information. First question coming in, we will not need new or separate CCBHC Medicaid numbers, correct?
For most clinics, you will not need a new Medicaid ID. And so we'll be able to take your existing Medicaid ID that links to the CCBHC site location and is either a Type 33 or Type 03 Medicaid enrollment. So the Type 33 is mental health, Type 03 is alcohol and drug providers. If we can locate a Medicaid ID that's existing in the system for your clinic, which for 11 of the 13 CCBHCs we've already confirmed that with, then we won't need you to enroll a additional site location or an additional Medicaid enrollment. For clinics that there's only a Type 33 mental health enrollment, if you're providing substance use disorder services, substance abuse prevention and treatment services that require the chemical dependency contract in order to adjudicate to a paid status, the claim to a paid status, in those cases, it's likely that you'd want to enroll that additional site location. So feel free to contact me directly, and I'd be happy to confirm the Medicaid IDs that we have on file for you, or if you'd need to enroll another site location. Again, we're only looking for enrollment for 2 site locations, or 2 CCBHCs at this point. All of the other CCBHCs are good to go, so we should be almost set for operations beginning April 1st.
All right, next question. We have a question from Elizabeth at CCS. We had to enroll for a new set for fee-for-service. Have you heard about that application?
That's a great question, Elizabeth. So we are waiting to hear from you on those new Medicaid IDs that you've established. Once those are finalized and you receive confirmation of the ID numbers, go ahead and send an email to me, and then we can establish your PPS encounter rates with those new Medicaid ID numbers.
All right, next question. In the update to the crosswalk, you included detox codes that are labeled as crisis. According to the crosswalk, those must be provided by the CCBHC, not a DCO, so we'll talk about DCOs a little bit later. Jamal previously stated that the key said it may be delivered by a DCO. What version is that?
That's a good question. I think I'll want to take that back to the CCBHC policy team, Emily Watson and Mike Morris. I know that in respect to crisis services, there are situations where a state-sanctioned crisis provider can operate as the DCO and provide that service for the CCBHC. But yeah, we'll take that back to the CCBHC policy team and provide a more thorough, comprehensive answer to that question. Great question.
Okay, next question. Will we be doing some testing before April 1st, the go-live date?
Yes, absolutely. We've been in the process of testing CCBHC billing from the state side for the past 2 to 3 months here. And everything appears to be operating according to plan, and we are on target for an April 1st go-live date. And so I believe that we'll go ahead and continue testing as we get closer to the deadline. We're not planning for any official testing between the CCBHC clinics and the state, but we are anticipating that starting April 1st, when you begin billing for CCBHC services at your encounter rate, payment should be issuing according to plan.
All right, so the next question has to do with DCOs, and I think we're going to get to it a little bit later, but I'm going to go ahead and read it now and we can touch on it. If the CCBHC is not a detox facility and chooses to contract with a DCO for this, if that's possible, is the CCBHC expected to bill for that using the PPS rate, or does the DCO bill for that?
That would be the CCBHC. So it's written within SAMHSA's criteria that the cost for your designated collaborating organization, or DCO, be built into your PPS encounter rate. Therefore, the CCBHC is responsible for all of the aspects of services provided by the DCO and should bill for the service provided by the DCO so that those costs are reimbursed through your PPS encounter rate. Now, if the CCBHC is billing for that service and then the DCO bills separately for that same service, that would be a duplicate payment, so that needs to be avoided at all costs.
All right, Jamal, can you speak a little bit to the DCOs and whether or not they need to be enrolled with Medicaid?
I don't believe that. I'm not entirely sure at this point.
So we'll check on that.
Yeah, we can definitely get back.
And I'm wondering if they would need to be in the rendering provider field on the claim,
right?
Or if the CCBHC is considered to be both the billing and the rendering in cases where the DCO is providing the service.
That's a great question.
Okay. Next question is, at quick glance, some of the G codes referenced in the CCBHC quality measures are not on the crosswalk.
I believe we will have additional meetings later on in the demonstration, I believe within the next 2 to 3 months, regarding the data requirements, so data queries, collecting the claims and codes that are necessary for quality measures. At this point, that's sort of outside of billing under the CCBHC program, so we'll definitely follow up at a later date regarding tracking the codes that are required for the quality measures. But today we'll just be addressing billing and the services that are captured on the CCBHC demonstration service crosswalk.
Okay, so there's a follow-up question from the DCO question and the CCBHC billing for that. It says, even though the CCBHC is not a licensed detox facility, so they would be billing for that even though?
Right. If the CCBHC is providing a procedure code that indicates they're providing a detox service, all of the same requirements to bill for that service would be in place as prior to the demonstration. So if you're billing for a detox service before launching on the demonstration program, then there would be certain requirements related to addictions and mental health that the clinic would need to acquire. So that same requirement would be in place post-demonstration if the CCBHC is billing for a procedure code that indicates that detox service has been provided.
Okay, next question. Do you have the required EDI file build so that you can send them to us for our EMR build?
We can certainly follow up with our electronic data interchange unit to ensure that they have the information that's needed, and we can provide that to the CCBHC clinics to allow for seamless electronic billing. So we will follow up on that as well.
All right, there's a couple of questions here about billing that I'm actually going to save until we get through the billing, because I think we may cover some of it in the billing and payment section. So questions that I can take right now. Let me see. Will there be more primary care procedure codes added to the crosswalk?
So right now, there are a good amount of primary care screening and monitoring procedure codes kind of listed in the section above the crosswalk, not necessarily within the list of codes below, but at the top of the crosswalk, you'll see a range of some of the 9.9 evaluation and management codes, or E&M codes. And so right now, that is the primary list of primary care screening and monitoring codes that we expect CCBHC clinics to bill for. But we will be periodically reviewing the list of demonstration services as the demonstration progresses.
Okay, so we have a couple of people on the line that are sending similar questions about the detox. So I'm just going to read the one because it kind of encompasses the other. To reiterate, we are not a licensed detox facility and do not currently bill for that. It sounds like the current setup is asking us to do that, though we would be contracting with a DCO. This needs additional attention.
Yeah, it's a great question. So I'll want to follow up with Emily Watson and Mike Morris to get a little bit more specifics around detox services, and then we'll take steps to ensure that you guys at the CCBHCs are fully informed as to what needs to happen when billing for detox services. So it's a great point, and we'll be sure to follow up as soon as possible on that aspect.
All right, so I'm going to go ahead with billing and payment. We do have a couple of questions sitting in the queue that have to do with billing and payment, and we will get to those in just a couple of minutes. So please stay tuned on those. All right, so let's talk about member eligibility and enrollment. So this is something that we kind of need to talk about every time we talk about billing and payment because it is a requirement. So requirements in regards to member eligibility and enrollment are the same as they were before the demonstration. So the Oregon Administrative Rules do require that any provider is verifying eligibility and coverage prior to seeing a patient. And covered services provided to OHP members are authorized and paid either directly by OHA, which means that that member is a fee-for-service or open card member, so you're billing OHA directly for those ones. And then the other option is that they might be authorized and paid through an OHA contracted plan. So that's where the CCOs or the MCOs come into place, where if a person is assigned to one of those organizations, then you are authorizing and billing services through that organization. And we'll talk a little bit later about payment and the wraparound process for members who are assigned to a plan. Okay, so the PPS rate, this is a daily rate. It's designed to pay once per day per patient when a CCBHC service is provided. So this PPS rate is only going to be paid for CCBHC procedure codes that are included in the crosswalk. And then all additional non-CCBHC services will be reimbursed in accordance with the reimbursement method that was in place prior to CCBHC. And then you'll see the link at the bottom of the page there. That's to the CCBHC billing guide that goes into this in a little bit more detail. It's also on that website that we previously visited. So it's down close to where that crosswalk is. There's a link where you'll be able to find this billing guide. Also, if you're in attendance with us today, this billing guide is available in the handouts section of the webinar, along with the slideshow and the wraparound payment Excel file. So you'll find those there. I also emailed it to everyone to the email address that you registered with for today's webinar. So you have it available in 2 places, and you can save that and hang on to it. So billing for open card or fee-for-service members, you're billing OHA directly. Please do remember that Medicaid is the payer of last resort. That means that if a person has private insurance or Medicare, that you're always billing those other parties before you bill Medicaid. So we are the last payer. For each CCBHC claim, you're going to follow these criteria here. Line 1 is where you would enter T1040. This is the pay code, as we call it, for the CCBHC encounter code. So you'll bill that with the PPS rate, and it should pay at the PPS rate. And then additional CCBHC services, you would enter those in the lines below. Those would reimburse. You would put your usual and customary charge, but they would reimburse at 0 because you've already received the PPS rate for line 1 under the T1040 pay code. You may also bill non-CCBHC services on the same claim, and those will pay per prior reimbursement method. So I do want to take a minute and maybe take a couple of questions. Wait, let me see. Yeah, because we can talk about CCOs in just a moment. I'd also like to show you a claim and how that works on the provider web portal. So I'm going to go ahead and pause for a second. And get over to the provider web portal. So here we're on the provider web portal. I'm going to go ahead and log in. Hopefully I have my password right. I think I just changed it. All right, I think I'm in anyway. Maybe not.
And sometimes it does that. You just kind of have to log in
Okay,
again and refresh.
Okay. Ah, there we are. Okay, so this looks a little bit different in some ways. I am on the provider web portal, but because I'm logging in as an Oregon State employee, my menu is a little bit different than yours, so don't let that throw you off. I'm going to go ahead and log in as a provider. All right, so I am logged in right now as a provider, and the claims menu is the same. So I'm going to go to claims and professional because you are a clinic and you're going to bill under the professional claim. So up here in the professional claim, I would enter the client ID. Once I've entered the client ID, then if I click in the next field or I click anywhere in the blue, that person's name and date of birth should come up. If that doesn't happen, then you want to use this search feature right here, and you can make sure that you have the ID correct. Other required fields here are the from and to date. Those are the only things that are required. However, just a couple of other things. If the member has any other insurance, you would want to enter the amount that you received from that other insurance in the TPL amount. And that would be the total amount received. So if you had a member who has private insurance, Medicare, and Medicaid, you would want to enter all of the amount that you received from both the private insurance and Medicare prior to our payment. I'm not going to go over it all in detail, but we have our diagnosis field here where you would enter primary diagnosis and any other diagnosis codes that you have. TPL section is where you would enter private insurance information. Medicare information, that's where you would enter information specifically about Medicare and what payments they may have made.
Medicare doesn't cover
if Medicare doesn't cover it, then you would just enter the date of the Medicare EOB. If you have something on a file that says that Medicare or TPL doesn't cover something, then it's okay for you to keep that on file and just enter the HIPAA adjustment reason code, and that works just fine. You'll see that in the TPL section that it's right here, adjustment reason code. But we still do expect you to enter something to let us know. Otherwise, our system will deny it because there's a prior payer that we don't see information for. So again, Medicare, you would put the date of the EOB if there were one. And then when you get down to the detail line, more Medicare information is right here per detail line. So this is where you would enter your HIPAA adjustment reason code for Medicare's EOB, or for them not covering the service if you have that on file. So now that we're at the details, actually this is really where we want to be and talk a little bit about the different line items. So required items, you've got your from and to date of service, your units, charges. So on line 1, maybe I'm doing line 1 for April 1st, 2017. Yes, that's a future date, so it actually wouldn't let that work, but that's the date that we begin. And I'm not going to submit, so this is really just an example. My TPS rate is 250, so I'm going to enter that there. Oh, wait, that's my units. I'm sorry. 1 unit, and then my PPS rate. The rendering provider is going to be the provider that's logged in unless you choose to enter something here. So we're just going to leave that one off and continue down the list here. My diagnosis code pointer, if I entered a diagnosis at the top and I wanted this to tie to my primary diagnosis, I would enter a 1. Modifiers, if needed, there's room for 4. Place of service, I'm going to put 12, or no, I'm not. I'm going to put 11 because that means clinic. And then this is line 1, so I'm going to put T1040. Now, if Medicare is not covering this and I have something on file, I'm going to put a 96 right here because that is a non-covered service. And I'm actually going to change this to 2016 because it's not going to let me move on. But remember, it begins on 4/1 of 2017. That's our first date that we will be billing for CCBHC. So my next step now, let's say this is my pay code. So this is line 1, T1040. So what I'm going to do is I'm going to click on the Add button here. And what Add does is it gives me an additional line on the provider web portal to put in an additional CCBHC service or even a non-CCBHC. In this case, again, this is the pay code, so I do need some more information. The system is going to want some CCBHC services. Oh yeah, it won't let me submit, but it'll let me do this, I think. All right, so here, what I'm going to see, I'm just going to scroll to the top of the detail section. So now my first line has kind of pulled up under the detail, and this is that first line item. If I were to click on it, it would allow me to look at that line item again and make changes if I needed to. But I also have line 2 now, and this will tell me which item I'm working on right now. So I'm going to go ahead and keep that date consistent. Again, these services are not going to be billable until April 1st of 2017, but I'm doing that so that the MMIS doesn't kind of kick that date out. So here I have 1 unit, and I don't know my charge for this. I don't know what, or I shouldn't say I don't know my charge. I don't have a charge, but I don't know what your usual and customary charge is. So I'm just going to put $120. And my diagnosis code pointer, modifiers, place of service 11 for clinic, and then I'm going to go ahead and put my H2023. That's one of our procedure codes there for CCBHC. And maybe I have some additional stuff to bill, maybe I don't. If you have additional stuff to bill, what you would do is go ahead and click Add again. You always want to click Add before you enter something, never after. Because if I click Add now, but I don't really have anything else to enter, what happens is I get that blank line up there. Ooh, a little too far. There we are, right at the top of detail again. So I get that blank line, and the MMIS is going to expect that I put some information there. So if I have a line item there and I don't have anything to fill out, then the claim's not even going to go through. So again, the reason I'm telling you that is because you want to click Add before you enter something, not after. So I'm going to go ahead and delete that line. I'll show you how that's done. Make sure that you've selected it. I can see I'm on line item 3 here. So what I can do is scroll back down to the bottom here and delete that line item. It asks if I'm sure I am, so I say OK. And now I'm back to only having my 1 and 2, line items 1 and 2. Now I will tell you, when you're putting in a rendering provider, if ever you need to enter that, I will repeat very quickly, if you don't put in a rendering provider, that the rendering provider is going to automatically be the provider that you are logged in under. So if you're logged in under your type 33 provider number, then the system is automatically going to assume that that's the provider that provided the service. So what you do want to do here is, if you are entering a rendering, you want to enter the National Provider Identifier, or NPI, of that rendering provider, not just their Medicaid ID.
Yeah, and just to clarify that point, so I believe that the rendering provider should have the NPI number of the clinic practitioner who actually provided that CCBHC demonstration service. So just wanted to clarify that piece.
All right, very good. And this is similar on paper. There are multiple line items where you can enter this information on a paper claim as well. And I'm going to go ahead back to our slideshow. Give me just a moment to get over there. All right, so let me make sure there are no questions there. We will talk about CCO members in just a moment, and then we'll go into the wraparound process. But I want to make sure that no one is confused. All right, our first question: providers are responsible for billing for their own services, and it's a CCO benefit, and we are not the payers, the CCO is. So I think this is in regards to when we were talking about the DCO, and that you would be billing for services that are provided by that DCO.
And we'll be addressing CCO billing in a moment.
Okay. How are you going to handle crossover claims from Medicare that will not have the T1040 code on the claim?
Nothing in 96 not covered?
It would be, but what happens is when you bill Medicare, they're just going to bill Medicare as they're supposed to, and those claims cross over automatically. So the claim comes into our system and it doesn't have the T1040. So I imagine what they'll do is they'll need to adjust those claims and add the T1040. And I don't know what Medicare's billing requirements are as far as that code goes.
Okay. Yeah, let us do a little bit of research on the Medicare crossover claims and follow up with some guidance on that in the next couple weeks.
All right, great question. Next question, does T1040 have to be in the first line? Our EMR's billing functionality does not have the capacity to dictate the first line. We will have to do a manual claims process if we have to put T1040 on the first line.
Yes, the T1040 code does need to be on the top line. That's something that in our guidance from CMS and SAMHSA, when they released the CCBHC encounter code, they did state that the way that they anticipated this working was for the T1040 code to be on the top level of the claim, and then the actual procedure codes for the demonstration to be on the additional detail lines. And so Oregon will be claiming an enhanced match rate from the federal government for CCBHC demonstration services. And the way that our financial division will be able to claim that enhanced match rate is by finding that T1040 code at the top level of the claim. So yes, T1040 does need to be at the top of the claim.
Okay, next question. Additional services are billed at the usual and customary charge. Will the 835 show paid on the services so that our system's AR is reconciled? So in case anyone doesn't know, an 835 is an electronic remittance advice if you are enrolled through our EDI. So the answer is yes. Those additional CCBHC services, you're billing them at your usual and customary charge. And it's similar to like when you bill Medicare and you have a crossover claim and we pay it at $0, but it shows as paid, but you just get $0 for it. That's exactly what's going to happen for these additional CCBHC services. So yes, they'll show paid, but they'll pay at $0. Next question, the most recent billing guide states that we do not need to bill the T1040 code at all for CCO clients. That is a change, correct?
Not necessarily a change, but that is correct. So billing the CCO for CCO enrolled members will be no change to your current process. And then as you submit that encounter data for the supplemental wraparound, we're not necessarily looking for that T1040 code. So you will not need to bill CCOs and managed care organizations that T1040 encounter code.
Right, that's our fee-for-service pay code, only on the fee-for-service or open card side. Next question, do you have an example of how additional CCBHC services would work? I'm not sure I understand what you mean by additional CCBHC services. So what we mean by that is any of the services that are included in the crosswalk. So those would be the additional CCBHC covered services, and they wouldn't necessarily be all of the services that you provide. So line item 1 is that pay code again, but that pay code is designed to pay your PPS rate for the services that you're also including on the claim. So any other services that are included in the crosswalk, you would want to be line 2, 3, however many lines, and bill your usual and customary charge. Does that make sense? I want to make sure that that makes sense. If it doesn't, please pop me up with another question there and we can get to that. So next question. Please tell me we don't have to do the billing manually as you're showing. We can still do it electronically, correct? Yes, you can still do it electronically. That was just an example of a provider web portal claim. No one has to do it manually. Next question, just to clarify the detox question. According to the state, CCBHC are only required to provide ambulatory detox and general detox services. Can be a contract MOU relationship and does not need to be a DCO. So the non-ambulatory detox services would be billed by the detox provider.
Okay. Thank you for the clarification. We'll be certain to bring that back to our CCBHC policy team.
Okay, so I'm seeing some repeats. No, you don't have to use the provider web portal. Use your current billing process. Okay, what if you are not a Medicare qualified provider? What would you put in as your TPL info? Okay, so TPL stands for third party liability. It's for private insurance not including Medicare. So if you are not a qualified Medicare provider, you wouldn't necessarily need to fill out any of that. You would only fill out TPL for private insurance. Upon our EDI file being set up correctly to reflect the PPS rates and CPT code. That ties to something else, okay. Should the PPS code always link to the primary diagnosis?
Yes.
Does this apply for QMB people with QMB coverage? So we're going to talk about that a little bit later. No, it does not. So people who have QMB, that's qualified Medicare beneficiary, indicated as med in our system, no, this does not apply for them or CALM clients, which is Citizen Alien Waived Emergency Medical.
So we've got another question about the electronic data interchange process and if there is any guidance regarding submitting electronically. We don't have that information within this training. However, we are planning to have a follow-up CCBHC training prior to go live on April 1st. So we will be sure to have that information for our next webinar on billing.
Okay, and then the next question has to do with are we doing each day separately when we bill? So I would think so.
Yeah, so the PPS rate is designed to be a daily rate. So for services provided on the individual day, you would be billing, and then in order to get the PPS rate for services provided on the next day, you'd be billing an additional claim in that respect.
All right, the next one has to do with a rendering provider. Other than the PPS code, are we supposed to submit an individual rendering provider for all claims? So that really depends on your process. If you don't enter a rendering provider, then our MMIS is going to assume that the clinic is the rendering. So if you do enter a rendering provider, please do enter the NPI, not the Medicaid provider ID. And right now it's the same as the current provider that you would be logged in as, right? Or that you would be billing as. Yeah, okay. Do you want to clarify that? Actually say that again?
Yeah, absolutely.
Okay.
So the requirements around the rendering provider will be unchanged under the CCBHC demonstration program. So if you're required to list the individual rendering provider of the practitioner, which I believe is the requirement, then that's going to be the same under the CCBHC demonstration.
All right, so I'm going to go ahead and move on and talk about CCO billing, just for the sake of time, and hopefully we can get back to some of these questions. that we still have coming in. All right, so billing for CCO or managed care members, you're billing the CCO or the managed care plan as you normally would. Again, remember Medicaid is the payer of last resort. So when you're billing the CCO or the managed care plan, you've already billed all other resources. And then OHA is going to supplement your payments up to the PPS rate through the supplemental wraparound payment process. So what you'll do is you're going to be reporting CCO and MCO paid encounters on a quarterly basis. All right, so the supplemental and wraparound payment Excel file is available over on the handout side over on the webinar panel. I also emailed it to you this morning if you're attending live today. Here's the process. You deliver the services, and this is for CCO members. You build the CCO or managed care plan, and then the CCO submits encounter data to our MMIS. And then the clinic each quarter submits CCBHC service encounters and payments received to OHP for the wraparound payment. So payment responsibilities, the provider, the clinic, is billing all available payers for services rendered. Again, we're the payer of last resort. You receive payment from all payers or an EOB from payers, or you have on file that Medicare does not cover this service so that you can bill with the ARC code 96 saying that it's a non-covered service. And then you submit quarterly reports to OHP to receive payments in aggregate up to the PPS encounter rate. And then staff here at OHP, we review the information submitted. I shouldn't say we, Eric, reviews the information submitted, compares it to the services that the CCO submitted for their encounter data, and then they calculate the wraparound payment. Here's the cover page of the template. So you would fill this out first, and then you'll see this is, when you first open the Excel file, you've got two tabs down here at the bottom. So you've got your cover page, that's basic information, and then you have this second tab here that's the raw data. And I'm not going to show you that in the slideshow, but please know that that is, again, in the handouts file, and I also emailed it to everyone attending live today. If you didn't get it, just type in your email address in the questions area. I'll make sure that you do get it, but we are going to talk about what's required. So the cover page, it includes costs incurred. So expected number of encounters from the encounters worksheet, the PPS encounter rate, and it includes all payments. So capitation amounts, CCO payments, Medicare, TPL, and any interim payments that you may have received from OHP.
Yeah, so that cover sheet is going to automatically calculate your PPS rate times the number of encounters for that quarter. So clinics will be submitting on a quarterly basis to start the demonstration. And that will give you the total reimbursable cost for the services provided as determined by your PPS encounter rate. Then what that will do is subtract out the, or establish the difference between the payments you indicate from CCOs and Medicare and other payers or the CCO enrolled members, and the difference between the total reimbursable cost and what you receive from other payers will give you kind of a preliminary estimate of what the wraparound payment will be. And then, of course, those encounters will go through the encounter validation process, which we'll talk about more here in just a moment.
All right, so that raw data tab that I did not click on, and that is, it would look too small in the slideshow anyway. These are the encounter details. So you need client information per encounter. So for each encounter, you're going to include the first and last name of the member and their Medicaid ID or prime number, same thing. and the encounter information, so date of service, procedure code, modifier, diagnosis, and the payments received for that specific service. So things that you're not reporting. You do not want to report payments. Do not report payments that were not for CCBHC encounters. So quality bonus payments would not be included in this payment amount. Also do not include services for members with QMB and CALM. We talked about that briefly. That question came in. Great question. There's your answer. And then do not include services that are provided under non-CCBHC site location. Eric, did you have anything to add?
What would that be? What kind of services would that be?
So residential treatment services, inpatient services. There are some services that SAMHSA carves out of the CCBHC demonstration. So really any procedure code that's not on the demonstration services crosswalk wouldn't be allowed for PTS reimbursement.
Right. So just because you can bill those services on the same claim doesn't mean that they would be included in your wraparound payment process. All right, and we do have some frequently asked questions, but I kind of feel like maybe we should take the additional questions that are coming in.
Yeah,
again, if you're attending live, you have this presentation, and there's some frequently asked questions at the end, and I'd really like for you to take a look at those. Now, we do have just a little bit more information that Jamal wants to talk about. We have some other billing considerations for CCBHC, and then we'll take as many questions from the audience as we can.
Yeah, so just to kind of go through this again really quickly here, I think that we already touched on DCOs and the need for DCO services to be billed by the CCBHC. The reason for this is DCO services should be captured in your PTS encounter rate. And under the SAMHSA criteria, which is linked here at the bottom, it indicates that the CCBHC is responsible for all of the provisions of services provided by the designated collaborating organization. So on to the next slide. We will be exploring an alternative process for the wraparound encounter data acquisition process. So currently, we'll be moving forward with clinics submitting their encounter data for the first quarter, but in the meantime, we will be determining an alternative process that would query the MMIS for your encounter data. And we do plan to report back on the feasibility of this alternative by June 5th.
All right, just some resources and contacts before we start taking those questions, and I'll leave them up in the background here. The CCBHC website, the crosswalk, the billing guide, all available with those links there, and both of them are also available on the CCBHC website, so that first link there includes the other two. And then contacts. So for the CCBHC contact email, we have an email address there. For program questions, you want to contact Jamal.
And please CC the ccbhc.grant email inbox when sending a question to me as well for tracking purposes.
Okay, and then for wraparound payment questions, you'll send those to Eric Larson. For training questions, you would send an email to Jennifer. And then for fee-for-service claims resolution, we do have our provider services unit available. And they can give you access to the provider web portal and also answer any claims questions. All right, so let's go ahead and dig into these questions here. And please know that if we don't get to your question, if you're attending live today, that I do have a record of all the questions, so we can take them back and explore them further. Also, we do have a webinar upcoming. We'll let you know when that is. Okay, so lots of individual billing questions. Do we include the TPL payment in the T1040 line, or does it get referenced in the CCBHC service line? So TPL payments are listed at the top of the claim. They're listed in the header of the claim. So it's not necessarily on the detail line for T1040. If a clinic is not an FQHC but a fee-for-service clinic, do they still get a PPS rate for these services, or do they stay at a fee-for-service rate?
None of the CCBHC clinics are FQHCs. It sounds like that's kind of in relation to the DCO question. So if there is an FQHC that is a designated collaborating organization for your clinic, and the cost for their services were factored into your PPS rate, then your CCBHC clinic would be expected to bill for that FQHC service at your PPS encounter rate, and the FQHC to not bill for that service at their PPS encounter rate.
Okay, next question. Just to clarify, if a client has coverage through a CCO and open card, are we going to bill open card as primary now? So a client should not have coverage through both an open card and a CCO. They have one or the other. Now, you do need to pay attention to the CCO, the type of CCO, because some of them include behavioral health and some of them don't, but most of them do. If you have any other questions about that, you can go ahead and email me. And this is Jennifer. Next, will you be providing a copy of how you would like the 837 for multiple claims per line to look?
Yeah, so once again, we'll be following up with more guidance regarding the electronic billing process or the electronic data interchange methods within our next training. So, and we'll try our best to get some information out well ahead of that as well, so you can begin to craft your billing processes around that.
Okay, what would you enter as your adjustment reason if no billing went into Medicare? So first of all, you only have to enter Medicare information for members who are covered by Medicare. Secondly, if you have on file that Medicare does not cover a specific service, it has to be something that's updated annually and is kept on file with your office, then you would be able to just bill us with the adjustment reason code for a non-covered service from Medicare without entering any other Medicare information. Can the state obtain the data for the supplemental payments from our CCOs directly?
Yeah, so that's what we'll be exploring fairly soon. Right now, the CCOs do submit the encounter data from all of their providers to the Medicare Management Information System, or MMIS. So we'll be exploring a process to automatically query and pull that data rather than having clinics submit the encounter data. But I do need to be clear, at this point, we are moving forward with the traditional wraparound process, which does include the clinic submitting the CCO encounter data in order to receive the supplemental wraparound payment.
Okay, I'm going to take one more question. We're at 10:01 right now. We don't receive payments for our CCO services. Our clinic is reimbursed with a capitation reimbursement model. Will the wraparound payment be whatever is above the Medicaid allowable for that code?
That's a great question. There are some slides that address capitation payments received from the CCO, risk withhold payments received from the CCO, also case rate payments. The way that we handle those are, when you're submitting for the wraparound payment, you should report the capitation payments that were received within the quarter. If your capitation payments are for CCBHC services, and then also for some non-CCBHC services, please work with your accounting department and finance managers to estimate the reasonable percentage of the capitation payment that is for CCBHC demonstration services, and then indicate that percentage as the amount of capitation payments received within that quarter.